To chair the first topic, I am pleased to welcome Dr. G. Vijay Kumar. Dr. G. Vijay Kumar, consultant diabetologist from Apollo Specialities and Diabetes Medicare Center, Chennai. Dr. G. Vijay Kumar has more than 30 publications in reputed Indian and international journals. He has also chaired and spoken in most of the national and international diabetes forums. I welcome Dr. G. Vijay Kumar to the dais to do the proceedings.
Good evening, and many thanks to MSD, Dr. Vijay, Dr. Padmanabhan, and all of you. Sachin. Today I am given the task of chairing a very good session about the dilemma amongst the physicians or the diabetologists who is treating diabetes. Because invariably we go for a combination therapy, and in the combination therapy the must molecule is Metformin. And you know, the understanding of diabetes is so good and of late. And then there is a growing concern and the paradigm shift in the management of type 2 diabetes, and we need to choose the right drug as an associated medicine for Metformin. See, global guidelines also mentions various drugs after Metformin, including the incretin-based therapies. Since we have many options, several options that are there, which are multiple in number, at least 6 or 7 molecules we have. And it is our duty to check the right choice of combination along with Metformin for the right patient at the right time. And today we are assembled here to enlighten us on why not gliptin as a good combination for Metformin. To convince us that gliptin is a very good combination along with Metformin, we have Dr. Rajiv Kovil, who is a senior consultant in diabetology from Mumbai. Apart from his regular diabetes care, he runs special clinics on prevention of diabetes and foot care clinic. A visiting consultant in several hospitals in Mumbai, published several papers in national and international journals, and is also involved in several clinical trials, and also is a member as an organizer in many organizations. Dr. Rajiv Kovil.
Thank you, Chairperson, for those kind words. Before I start, I'd like to thank BG and the organizers of this event for a fantastic event in a palace like this hotel. Thank you so much for having me here. Today I'm going to talk about whether there is a dilemma in choosing drugs after Metformin. And I personally don't think there is a dilemma. I'm Dr. Rajiv Kovil from Bombay, have 2 centers in the western suburbs of Bombay. And I'm going to talk about what after Metformin. Most important thing that we need to realize is that type 2 diabetes is a very complex problem, and we should not be glucocentric in our approach. We should be taking the patient's confidence, the patient's, a lot of patient's role in deciding what kind of therapy we choose, because finally after he leaves our cabin, he's going to focus on his lifestyle depending upon the kind of counseling we have given him. So the ADA ESD position statement also says that we should gauge the patient's preferred level of involvement, explore where possible therapeutic choices, utilize decision aids, and there should be a shared decision making. Most importantly, these are guidelines, ADA ESD guidelines. Obviously for a normal weight, underweight, overweight, type 2 diabetic, Metformin is the base therapy. After that, you could add a TZD, you could add an SU, you could add a DPP4, you could add a GLP-1 or a basal insulin analog. Now, what happens actually in clinical practice is quite different than what happens according to guidelines. Guidelines only tell us it's not a mandate. As I said, type 2 diabetes is very complex. We don't want the patients to call up the next day morning with hypoglycemia. We want our drugs to be durable, to be lasting a long time. We don't want complex dosing. We don't want any of the oral antidiabetic having any CV or renal side effects. We don't want hypoglycemia. We don't want weight gain. And we want a good 24-hour control. So patient requires all this, and that's what he comes to us for. So in this setting, we need to have drugs which can kind of comply with all these things. When I was studying diabetology 2 decades back, there was only beta cell dysfunction, then came insulin resistance. Now we have 8 pathophysiological defects, and we need to treat all of them. With the help of X-ray crystallography and reverse molecular mimicry, we've been able to identify what are these pathophysiological defects in type 2 diabetics. And nowadays, companies are kind of designing molecules to kind of feature on these defects. The TZDs and the DPP4 inhibitors are prime examples of how we have designer molecules for it. The ADA targets remain the same. We need to have very, very tight glycemic control for all our type 2 diabetics. Unfortunately, 50% of patients across the globe are in poor diabetes control. So why is metformin not enough? Studies tell us that beyond a 1500 milligram of metformin, there is no incremental reduction in HbA1c. On the contrary, the GI side effects go up. And this holds true for every possible molecule. We should add on a molecule before we go on to the maximal dosage of any particular molecule. So never go on to a maximal dose. Add is a dictum in diabetes and not replace. This is the Belfast diet study, which kind of monitored patients who were on diet for a long period of up to a decade. And what it told us is that insulin sensitivity or insulin resistance is a pathophysiological defect which continues all throughout the disorder. It remains the same. While beta cell dysfunction at diagnosis is almost 50%, and it progresses with time. The UKPDS actually confirmed this, saying that diabetes is a progressive beta cell failure. So we need to understand that we need to give molecules which kind of don't worsen this beta cell dysfunction, because that's what is going to make glycemic excursions, and that's what is going to make complications. So insulin resistance is going to remain the same in our patients with type 2 diabetes. So what are the decision points that we have while choosing a drug therapy? Efficacy, hypoglycemia, weight, CV safety, whether it preserves beta cells, compliance of patients, cost, and whether it has a good mechanism of action. Now let's look at efficacy. This was a study published almost 7-8 years back, done on approximately 1,000 odd patients, and was done to assess the efficacy of a combination of sitagliptin plus metformin in patients who are failing to metformin monotherapy. And over a 24-week period, sitagliptin caused a good 2% reduction in HbA1c. These were patients between an HbA1c of 7.5 to 11, and this is what we also see in clinical practice. Most importantly, all these patients tolerated the sitagliptin metformin combination with no desirable or undesirable side effects. In this, there was also an open label study which focused on a HbA1c of more than 11, and that caused almost 2.9% reduction in HbA1c in those patients who had an HbA1c of more than 11. Sitagliptin combination with metformin also caused a decent reduction in FPG and PPG, as you can see on the slide, 3.9 millimoles and 6.5 millimoles in PPG. And in the open labeled arm, it caused 11.6 milligram reduction in fasting plasma glucose. The next step, when metformin fails, what comes onto our mind? This study was specifically done to address that question, whether they assess the efficacy of adding on a DPP4 inhibitor versus an SU when patients are on ongoing metformin therapy. And you have two sets of studies here. The one on the left is a 2-year study versus glipizide, and the one on the right is a 30-week study with glimepiride. And what it conclusively shows is that the glycemic efficacy of adding sitagliptin to metformin was almost equal to adding glipizide to metformin or glimepiride to metformin. So in terms of glycemic efficacy, they were the same. The durability of sitagliptin metformin was much better. The beta cell dysfunction deteriorated much lesser with sitagliptin. The hypoglycemia was much lesser with sitagliptin metformin. And also the weight loss was much better with sitagliptin metformin, and on the contrary, you had weight gain with an SU plus metformin. Another question in physician's mind is always, are the DPP-4 working as quick as SUs? Because when patient comes to a doctor, the patient would do the blood sugar the next week and report that my sugars are still high. So this is always a query, that whether the DPP-4 inhibitors work as fast as an SU would work. And this specific study was done in an elderly group, which is an area where not many studies are done. So this is a study done in patients more than 65 years of age. The mean age of patients was almost 72. The mean HbA1c was almost 7.8. It's a randomized, double-blind, placebo-controlled parallel group studies conducted in almost 52 sites. And it shows that right from the third day onwards, you have a decent drop of fasting plasma glucose and average blood glucose when patients are added to an SU. This is a monotherapy of sitagliptin, and it conclusively shows that it is quick and efficacious, and fairly efficacious in patients above 65 years of age. So in terms of efficacy, when you have to choose between an SU and a DPP-4, especially sitagliptin, is almost the same. So that query or cobweb in our mind is cleared. The next comes hypoglycemia. We don't want patients to call up the next day morning saying that I'm in hypoglycemia. And again, the same study between the 2-year study comparing a combination of sitagliptin plus metformin versus glipizide plus metformin, and sitagliptin plus metformin versus glimepiride plus metformin. You can see there's a large difference in hypoglycemic rate between the SU-MET combination and the DPP-4-MET combination. Obviously, patients who are on DPP-4-MET combination are on much lesser risk of hypoglycemia as compared to SU plus MET combination. This is a kind of sub-analysis of the same study, and what it shows is that patients who are on glipizide plus metformin combination have a much, much higher risk, almost 448 events as compared to probably just 31 events with sitagliptin plus metformin. What is most striking is that patients above the age of 65 who are using glipizide plus metformin have a higher incidence of hypoglycemia as compared to patients who are using glipizide plus metformin below the age of 65. And if we compare sitagliptin metformin in the age groups below 65 or above 65, the incidence rate remains the same. So probably SUs give much higher chances of hypoglycemia in elderly age groups. We don't know the mechanism, probably hypo-unawareness, probably beta cell fatigue, probably social considerations, we really don't know, but SUs above the age of 65 is giving a much higher incidence of hypoglycemia as compared to SU plus MET below the age of 65. So especially in our age groups above 65, as we saw in the previous study also, it's efficacious, it's quick, lesser hypoglycemia, and obviously lesser weight gain. This was a study by Dr. Arvind, which was published around 2 years back, and this was done during this time, that's Ramzan season, and it was just switching patients who are on SU combinations to a DPP-4 combination, especially sitagliptin, and what it showed is that there was a 50% reduction in hypoglycemia. This was a study done in Southeast Asia, and it told us that especially during the Ramzan months, if you just switch over from a SU to DPP-4 MET, the chances of getting hypoglycemia is reduced by almost 50%. And this holds true in real life scenario also. The DIREGIS study was a registry from Germany in primary care setting, and it also told us the same thing, that sitagliptin plus SU in a real world, they almost had 3,810 patients, and the reduction in plasma glucose was much better than with a DPP-4 metformin, and much lesser incidence of hypoglycemia. Weight is a very important factor because we are treating diabetes, which also involves a lot of quality of life issues. And if you compare the weight difference using sitagliptin metformin versus glipizide metformin, or sitagliptin metformin versus glimepiride metformin, the weight difference is as high as 2.3 to 2 kilograms. The study on the left is a 2-year study, the study on the right is a 30-week study. So you have a difference of almost 2.5 kilograms. So that's something which we need to keep in mind when we are actually choosing a molecule after metformin. CV safety. CV safety has always been on our forefront and in our minds, because majority of our diabetics are going to die of heart disease. There was a myth around 15 years back that some of the newer SUs have lesser cardiac side effects. The UGDP controversy almost 40 years back has still not died down, and a lot of authors still think that probably SUs have some cardiovascular effect, and we need to be careful while prescribing SUs. Meta-analysis using SU versus gliptin on CV outcome conclusively shows that the CV outcomes using a DPP-4 combination is much better. The cardiovascular safety of sulfonylureas have always been a question mark, and a meta-analysis was done including all trials with a duration of more than six months. There are almost more than 100 trials in this, and it showed conclusively that the use of SU is associated with increased mortality and a higher risk of stroke, whereas the overall incidence of major adverse cardiovascular events appears to be unaffected. It again told us that probably we need to use medications which have glucose-lowering agents, which have glucose-lowering effects and not much of cardiovascular problems such as the DPP-4 inhibitors. This was a poster which was, I think, came in last year's ADA, and the aim of this study was to evaluate the risk of all-cause mortality. We are not looking at cardiovascular disease and all-cause mortality, and patients who were on SU combinations were compared to DPP-4 combination, and the conclusion was there was a consistent reduction in mortality for patients prescribing metformin in combination with DPP-4 versus metformin in combination with SU. These data should be considered because apart from cardiovascular disease, the all-cause mortality in our diabetic population is very high. By the end of the year, we would have TECOS which comes in, and probably we would have much more analysis of it, and we'll have a prospective study which tells us the cardiovascular safety of sitagliptin. We need to understand that whenever we prescribe a molecule, we need to take into consideration a lot of comorbidities, whether it's coronary artery disease, heart failure, CKD status, liver status, NAFLDs, hypoglycemic risk, social status of the patient, what is his immediate help, all these things need to take into consideration. And then we have all the other OADs on the right, which are metformin, SUs, TZDs, and also the effect of incretin-based therapies. Durability is something which we need to really look at. We've always seen or heard studies which tell us that probably there is beta cell dysfunction which occurs in type 2 diabetes, and this is a progressive disorder. But we've never had actual data showing that, and this is the data which is obtained from pancreatic islets, which are isolated from 6 type 2 diabetes organ donors and 10 non-diabetic cadaveric organ donors, which tell us that there's increased beta cell apoptosis which occurs in type 2 diabetes. There's decreased insulin content in these islets in type 2 diabetes, and the insulin secretory granules are also much lesser in these patients. And we need to understand that we have a patient who has almost beta cell dysfunction of 50 to 70%, and it is progressing with time. There's a clinical entity called secondary sulfonylurea failure, that once we use a 1 milligram dose of a drug, 6 months later you're going up to 2, a year later you're going up to 4, and finally the patient is on insulin. We sometimes say that it's because of the progressive nature of type 2 diabetes, but we never wonder that probably it's also the drug which is causing it. And that there is some evidence to that, because the SUs keep on stimulating the pancreas even in the absence of glucose. The sustained influx of calcium which occurs is known to cause apoptosis in beta cells. And the conclusion of this study was that SU should be delayed as long as possible because there is increased apoptosis with SU use. We've also not understood that why do we have apoptosis. This was another study where they examined the effects of various sulfonylureas and a short-acting natiglinide on oxidative stress and apoptosis using a beta cell line MIN6. And what it shows is that there is oxidative stress which occurs when we use sulfonylurea therapy, and probably that is the hypothesis which may be contributing to sulfonylurea failure very early in type 2 diabetes. So sulfonylurea beta cell apoptosis does occur in vitro, and we need to find that out. And that's probably one of the reasons that we all know that the sulfonylureas do not have durability. And the whole idea of treating to fail approach doesn't hold true. We need to be much more proactive and probably attack much earlier. So we know that the sulfonylureas lack glycemic durability, and they fail to prevent the progressive decline of beta cell over a period of time. ADOPT study the larger monotherapy failure with glibenclamide was seen. It showed that the TZDs had a durability effect. Unfortunately, now the TZDs have gone out of repute. But as such, the annual rate of decline in HOMA beta was highest with sulfonylurea versus metformin and then TZD, ultimately mirroring a lack of beta cell survival. In terms of durability, sitagliptin is fairly durable as monotherapy or add-on therapy, as you can see over a period of 2 years. That's what we want, one single dose, no complex situations, durability, patient has good HbA1c for a prolonged period of time. And sitagliptin improves certain markers of beta cell function, whether it's pro-insulin-insulin ratio or reduces the insulin resistance as measured by the HOMA-B. This is a study which was done to assess the efficacy of an add-on as a third drug of sitagliptin versus glibenclamide on patients who are already on pioglitazone metformin, was published around last year, and it told us all the factors which are in favor of beta cell dysfunction are increased with therapy with an SU, whether it's the pro-insulin-insulin ratio or it's the increase in HOMA resistance. So sitagliptin and beta cell markers, one can say that sitagliptin improves the insulin secretory capacity, reduces insulin resistance, and it reduces the beta cell stress and the immature insulin. So in terms of choosing which drug to choose, we have had a lot of reasons that why we should be choosing sitagliptin. Cost, I think cost is in terms of a scientific conversation, of a scientific dialogue or a debate, I don't think cost should be a factor at all. And 1,000 rupees per month is not a factor if you have to prevent large-scale diabetes complications, which may go up to lakhs of rupees per month. So in terms of cost, I don't think cost is a major factor. But what does the algorithm of ACE say? That therapies with complementary mechanism of action must typically be used in combination for optimal glycemic control. Safety and efficacy should be given higher priorities. One hypoglycemic episode in the city of Mumbai would cost around 20,000 rupees a day. So 1,000 rupees a month is not much. So in terms of cost, I don't think there should be a scientific discussion. In terms of mechanism of action, I'm told Dr. Avdesh Kumar is going to tell us more about how DPP-4 acts, not via the GLP-1 action. But one needs to understand that most of these DPP-4 inhibitors are acting only when the glucose is high. Glucose is the best stimulator of insulin secretion. What it does, it increases the ATP-ADP ratio, potassium channel closes, the calcium channels open up, calcium influx, and you have exocytosis of insulin. Now, in the absence of glucose, these DPP-4 inhibitors do not work. They need the presence of glucose, then only they work, which makes DPP-4 inhibitors actually insulinotropic. So they are like a smart drug which work when the sugars are high and do not work when the sugars are low, making our quality of life and the patient's quality of life much, much better. I think I've given enough reasons for using sitagliptin as a first choice following metformin failure. And also one needs to understand that paradoxical hyperglucagonemia is a pathophysiological defect in patients with type 2 diabetes. I can see Shashank smiling there. Paradoxical hyperglucagonemia is a defect which we have known, and probably we need drugs to kind of reduce on that kind of defect. And we have a drug which has a desirable mechanism of action, has good efficacy, cost is around 1,000 rupees a month. In terms of some cases of pancreatitis, this is by Dr. Garg, which was presented almost 4 years back. Retrospective data told us that the incidence of pancreatitis is high in patients with type 2 diabetes, but there was no association which was found between the usage of a GLP-1 or a DPP-4 and pancreatitis. So that clears our doubt. The FDA sides with the EMA on the usage of this drug. And in terms of all possible benefits, if you can compare the two, if 1,000 rupees a day to prevent a 5 lakh rupee deficit is not much, we should all be using DPP-4 inhibitors as the first choice after metformin. So when we have options, what do we have to do? If we have to avoid hypoglycemia, we have to use metformin, DPP-4, TZDs, or a GLP-1 receptor analog. If you have to avoid weight gain, metformin, DPP-4, or GLP-1 receptor analog. Minimize the cost, you have to add metformin, SU, and insulin. No longer insulins are cheaper. So choosing a right partner for metformin, I don't think there is a dilemma. We have to choose the right drug, and that seems to be a DPP-4 inhibitor. Metformin is the initial preferred agent in diabetes after diet and exercise. There's a myth that SU has a stronger anti-diabetic action, but with a much higher risk of weight gain and hypoglycemia. SU has a long track record. Gliptins are new, available evidence showing good side effect profile. Possible beta cell preservation and CV benefits are major positives of gliptins versus SU. Gliptins probably may be costlier than SU, but we need to make a cost-benefit ratio there. And I hope, I hope I have helped you all in devising a strategy. This is the team which helps me in my clinic. Thank you so much.